Okay. Okay. We have our second part of this lecture. As we have learned previously as well, the physiological changes in pregnancy that are uh, to be noticed. These are all the adaptations of maternal different systemic changes so as to fulfill the demands of the growing fetus within the mother. Okay, so this is basically the phenomenon of maternal adaptation to the increasing demands of growing fetus. Today we are going to learn about the changes in different systems like the changes in the reproductive tract, different skin changes, changes in the breast, metabolic changes, hematological changes, changes in the renal system, GI system, and endocrinal system. Okay, uh, in the female reproductive tract, the organs become hypertrophied and there is increased secretion of glands. For example, there is increased vascularity of cervix, vagina, vestibule. Okay, and you can notice some bluish discoloration of the mucosa. This is also known as Jacquemuir's or Chadwick's sign. There is increased vaginal secretion, so the females with pregnancy may complain with increased vaginal secretion and discharge. Patient may come to OPD with those complaints. So in those situations, unless the discharge is copious in amount, foul smelling, associated with any passage of blood, or associated with itching, this should be considered normal. So if these the the things I just told you about, if any of these signs are present, then that is pathological. Otherwise, some amount of increase in vaginal secretion is normal in pregnancy. Okay. Regarding the pH of the vaginal fluid, it is acidic because the glycogen is converted to lactic acid because of the effect of increased estrogen in pregnancy. The uterus becomes soft, cervix becomes soft, and there is cyanosis. So you will see the bluish discoloration. Uh, Sorry, can you hear me?
Yeah.
Okay, okay.
Done.
Mm.
Oh,
Okay, and you can also notice some of the erosions present in the cervix. Okay, the cervical erosion is normal in pregnancy. You will also find some amount of thick mucus like discharge in the cervix that when thickens becomes a mucus plug. It is the passage of this mucus plug that leads to uh, bloody show at labor. Okay, before the labor is onset, before there is onset of labor, patient present with passage of blood mixed mucoid discharge. Okay, this is a sign of early labor. This blood mixed mucoid discharge is because of the passage of mucus plug, which is formed by thickening of the mucus in the cervical os. The uterus grows in size, as you know. The normal uterine weight is 70 gram in non-pregnant state. In pregnancy, this can increase to 1.1 kg. Similarly, the cavity of the non-pregnant uterus is just about 10 ml, and it can accommodate up to 5 liters of fluid and the fetus during pregnancy at term. Okay, this increase in size of the uterus is contributed mainly by the hypertrophy of the muscles and stressing of these muscles. Okay, there is also increased vascularity and there is increased supply of the lymphatics. All of these contribute to the increase in size of uterus. Uterus is usually firm in consistency, okay, in non-pregnant state, but in early pregnancy the uterus gradually becomes soft and it becomes more distensible, and in late pregnancy the thickness of the uterine wall is up to 1.5 centimeter. Okay, this is quite thick, so as to support the fetus and the contents of the amniotic sac. If you look at the muscles of the uterus, the muscles are arranged in three layers. There is the outer longitudinal layer, there is the inner circular layer, and in between there is the middle interlacing layer. So there is crisscrossing of the muscle fibers. Okay, this crisscrossing of the muscle fibers is a very important feature in mammals, because this helps in preventing blood loss after delivery. So what happens after delivery is the decidua or the endometrium of the uterus is exposed. Okay, once the fetus is delivered, the placenta is delivered, the sinusoids will be open, the veins will be open in the cavity, so there will be more flow of blood. But because of the contraction of these muscle fibers, which are arranged in crisscross pattern, this contraction leads to contraction of the blood vessels that are within the muscle fibers. Okay, so this acts as a hemostat. Did you get my point? Are you hearing me?
Yes, sir.
Okay. Okay. If you look at the shape of the uterus, okay, with increase in gestational age, you will notice that the size and shape of the uterus gradually change. Okay. In non-pregnant state, the uterus is pyriform in shape, that is pear shaped. But as the uterus enlarges, it becomes globular. By 12 weeks, you'll see that you'll feel that the uterus is globular in shape, and it becomes an abdominal organ once the uterus is 12 weeks size. Okay, before 12 weeks size, if you palpate per abdominally, you will not feel the uterus. But once the 12 weeks mark is passed, then the uterus becomes palpable per abdomen. Okay, before 12 weeks, you'll have to feel the uterus only by per vaginal examination. You can't feel by per abdominal examination. So the uterus becomes a abdominal organ after 12 weeks. Okay, and as the uterus enlarges, it becomes ovoid or pyriform shaped at 28 weeks period of gestation. Then after that, it becomes more spherical in shape. And another important thing about the uterus is that the uterus becomes dextrorotated. Dextrorotated means the uterus is rotated towards the right side. Okay, this right side rotation of the uterus is because of the presence of rectosigmoid on the left side. Okay, and because of this right-sided rotation of the uterus, there are different changes that you'll see. Okay, for example, because of the dextral rotation of the uterus compresses on the major veins like vena cava and aorta. Okay, that leads to the supine hypotension syndrome that we talked in our previous class. Similarly, when the uterus is rotated towards the right side, it compresses on the ureter on the right side. So when the right ureter is compressed, what happens? There will be backlog of urine in the ureter as well as the uterine pelvis. Sorry, the renal pelvis. Okay, so there is hydronephrosis and hydroureter. Hydronephrosis is the collection of urine in the kidney, okay, in renal pelvis, and hydroureter is the collection of urine or engorgement of the ureter because of compression at some distal point. Okay. Next thing is a change in endometrium. Okay, the endometrium of pregnancy is in pregnancy, the endometrium is known as decidua. Okay, this is a typical term used for endometrium of pregnant uterus. This decidua has three layers. The superficial layer is known as the compact layer. The middle layer is the spongy layer or stratum spongiosum. Superficial layer is compact layer or stratum compactum. Intermediate layer is stratum spongiosum, and the basal layer is stratum basalis. Okay, these are the three layers of the decidua of a pregnant uterus. This specific layering of the endometrium can be noticed in a pregnant uterus. Now let us go to the formation of lower uterine segment. Okay, as you all know, isthmus is an area between anatomical internal os and histological internal os. Okay, anatomical internal os lies superiorly, histological internal os lies inferiorly. Okay, histological internal os is a point where there is change in the lining epithelium, right? And anatomical internal os is the area where there is constriction between the uterine body and the cervix. Okay, so this area is almost 0.5 centimeter in length. Okay, this is 0.5 centimeter length in non-pregnant uterus. But as uterus enlarges in size during pregnancy, what happens is this 0.5 centimeter length area gradually progresses. Okay, it gradually increases in size, and this increase in size of this isthmus leads to the formation of lower uterine segment. And this is the lower uterine segment. This is the specific area where we give incision in the uterus while delivering the baby by cesarean section. Okay, so the formation of lower uterine segment is another physiological change in pregnancy. Now, the change in contractility. Okay, even in early trimester, what a pregnant lady will have is she can have some painless irregular contractions. Okay, however, this will not be detected by the lady. However, in second trimester, the intensity of contraction gradually increases. Okay, this rises to a value of 5 to 25 millimeters of mercury. This is known as Braxton Hicks contraction because this was first identified by the scientist Braxton Hicks. Okay, and at the time of labor or immediately before labor, there is painful regular uterine contraction. Okay, compared or contrast to the Braxton Hicks contraction, during labor the contraction is more painful. It is more regular. It is more increasing in intensity. Okay, the intensity of pain is more, and it comes at more frequent intervals. Okay, Braxton Hicks contraction could come as half an hour to 1 hour apart. However, if the patient is in labor, this contraction occurs every 2 to 3 minutes. Okay, 2 to 3 minutes to 5 minutes. So the contraction or labor pain is different from that of Braxton Hicks contraction. However, there is contractility that is present from the first trimester, detectable from the second trimester, and is more painful, regular, and more frequent in third trimester immediately before the delivery or during the time of delivery. Okay. Now, regarding the uteroplacental flow we have discussed in the last class, the uterus and ovaries are supplied by the uterine and ovarian arteries. Okay, there is utero-ovarian anastomosis, and there is increased vascularity of the reproductive organs during pregnancy. So the uteroplacental flow is increased. Okay, this is as high up to 650 to 750 milliliters per minute at term. Ovary, as you know, after a lady becomes pregnant, ovulation ceases. Okay, there will not be further ovulation. There will be single corpus luteum of pregnancy. Okay, the fallopian tube also undergoes some hypertrophy, and the tubal mucosa of the epithelium becomes the epithelium of the tubal mucosa becomes flattened. Okay, the fallopian tube epithelium becomes flattened. Now let us go to the skin changes in pregnancy. Okay, in skin, if you notice a pregnant lady, especially in second trimester, you will notice that her face shows some brownish black discoloration. Okay, this is known as cloasma gravidarum. Gravidarum stands for pregnancy, and cloasma is a increased pigmentation of the skin. Okay, this is also known as melasma. This cloasma gravidarum is localized more over the cheeks, forehead, and around the eyes. However, this may be generalized or patchy. Okay, you can see in this lady that there is brownish discoloration. Okay, like butterfly-like rash. You can see here. It's more prominent in the cheeks, the nose. Okay, in some ladies, you will also see the discoloration in the forehead, and in some, the whole of the face may be discolored. However, this is more prominent in cheeks, forehead, and the nose. Okay, this is known as cloasma gravidarum. Okay, are you all with me?
Yes,
Yes,
sir.
sir.
Okay. Another change that was the change that we just saw was a change in face. Okay, cutaneous change in the face. Now in the body, you'll notice brownish black linear line. Okay, there is a linear pigmentation that goes from xiphisternum to the symphysis pubis. This is known as linea nigra. Okay, this cutaneous, all of these cutaneous changes are because of increase in melanin. Okay, because of the hormone MSH, melanocyte secreting hormone. In pregnancy, linea nigra is a brownish black discoloration that goes from xiphisternum to symphysis pubis. Okay, as a single line. Okay, this is very prominently seen here in this lady. In the next diagram, you see stria gravidarum. Stria gravidarum refers to some pinkish red discoloration that is more localized in abdomen. In some cases, you will notice this change even in the breasts and in upper thighs of pregnant females. Okay, this is because of the scarring of the tissue under the skin. Under the skin, because of increasing stress, the tissue will be injured. So when the injured tissue heals by scarring. Because of this scarring, you will notice this stria. Okay, this is stria gravidarum. Once the lady goes to the postpartum period, this is called stria albicans. Okay, when she is pregnant, it's called stria gravidarum. When she is uh, when she goes away from pregnancy, that is after postpartum period, it is called stria albicans. Okay. Now, next cutaneous change is spider navy. Spider navy you might have noticed in patients with chronic liver disease. Okay, if you have studied about liver cirrhosis, you'll notice that spider navy is one of the diagnostic sign. Here, what you see is there will be a central arteriole, okay, like a pinhead, and surrounding that central area, there will be some fiber-like vessels seen. If you press the pinpoint center, the increased redness in the surrounding area also disappear. Okay, this is known as spider navy, like that of a spider. This is also seen in chronic liver disease. Okay, however, in pregnancy, this is common, and this is because of the effect of estrogen. Another change is palmar erythema. Okay, palmar erythema is uh, pinkish pigmentation of palms. This is also because of the effect of estrogen. Okay, and this can also be seen in patients with chronic liver disease. So, can anyone tell or recall the cutaneous changes that we have just read? Anyone? Just for revision. Plasma gravidarum on the face. Okay. Linea nigra and stria gravidarum in the abdomen, upper thighs, and breast. Okay, stria gravidarum can maybe present in the breast, upper thigh, more present in the abdomen. And spider navy and palmar erythema. Okay, all of these are the cutaneous changes. Now, another cutaneous change is seen in the breasts. What happens is breasts during pregnancy enlarge in size. Okay, the not only the overall size of the breast but also the nipples enlarge in size, and there is increased vascularity. So you will see some bluish veins running under the skin in case of pregnant females. Okay, there is pronounced pigmentation of primary areola and nipple. The primary areola, this is the primary areola. Okay, this primary areola and the nipple becomes more pigmented. Nipple is enlarged, this primary areola becomes more pigmented. There is also presence of or appearance of secondary areola. Secondary areola is an area that lies just outside of the primary areola and is less pigmented than the primary areola. Okay, this area is the secondary areola. Sorry, this is the secondary areola. Similarly, there will be presence of Montgomery tubercles. These tubercles are nothing but the dilatation and enlargement of the sebaceous glands that are present underneath the primary and the secondary areola. Okay, these are known as the Montgomery tubercles. In pregnancy, some form of breast tenderness or breast pain is common. Okay, this may range from tingling sensation to frank pain. And you'd also notice some secretion from the breast as early as 12 weeks if you compress or press the breast, and you'll notice the colostrum secretion from after 16 weeks. Okay, these are the breast changes in pregnancy. Now, if you look at the metabolic changes, as you can understand, during pregnancy, the mother has to supply the nutrients not only to herself but also to the fetus. So, there is an additional 300 kilocalorie per day energy requirement for the pregnant lady. Okay, and on average, a pregnant lady gains about 11.5 to 12.5 kg of weight. Okay, this weight gain is divided into the for the fetus as well as the mother. Okay, in the mother there is increase in uterine size, breast increase in size, there is more amount of blood. Okay, extravascular fluid also increases, there is increased accumulation of fat. Similarly in the fetus, uh, fetal part, there will be fetal weight of up to 3.5 kg or up to 4 kg in some cases. There will be some amniotic fluid up to 1 liter at around 36 weeks, then that gradually decreases, and there will be some weight of the placenta. Okay, that ranges from 500 to 700 gram. Okay, all of these lead to increase in weight of the mother, and the average increase in weight is about 11.5 to 12.5 kgs. Okay, now regarding the water metabolism, okay, there is fluid retention during pregnancy. Around 6.5 liters of fluid is retained in the pregnant mother, and this fluid retention is primarily because of the effect of hormone aldosterone. Okay, aldosterone and corticosterone are increased in pregnancy. These are released by the endocrine glands, and this hormone leads to increased accumulation of fluid. Similarly, there should be some protein gain in pregnancy. Okay, this is divided among the for the fetus and placenta as well as the mother. Okay, in the mother, this protein is used for the formation and increase of contractile proteins, increase in breast size, formation of hemoglobin and other plasma proteins. Now, regarding carbohydrate metabolism, pregnancy is a potentially diabetogenic state. Okay, that means uh, this is a condition where diabetes can be first diagnosed or developed. There is some form of mild fasting hypoglycemia. That means during the fasting state, there will be hypoglycemia. And in the postprandial state, there is hyperglycemia. So there is mild fasting hypoglycemia and postprandial hyperglycemia. Okay, this is because of the effect of increase in insulin. Okay, during pregnancy, the amount of insulin is increased. So there is hyperinsulinemia. This leads to mild fasting hypoglycemia and postprandial hyperglycemia. And this increase in insulin is because of the effect of hormones like estrogen, progesterone, and human placental lactogen. Okay, these are the hormones which lead to some resistance of insulin. So though the insulin is present, it will not be as effective as in the non-pregnant state. So what happens is the body tries to compensate for the decreased effect of insulin by increasing the amount of insulin. So there is increase in amount of insulin, there is hyperinsulinemia. However, there is some insulin resistance. Okay, all of these conditions like mild fasting hypoglycemia, postprandial hyperglycemia, hyperinsulinemia, all of these conditions are to make sure that the fetus gets enough amount of glucose from the mother. Okay. Now, regarding the iron metabolism, okay, during pregnancy, the total amount of iron needed is 1 kilogram. Okay, 1 kg of iron is needed. Sorry, 1000 milligram of iron is needed. Okay, this 1000 milligram of iron is divided among RBCs, fetus and placenta, and some insensible loss to contribute for some insensible loss. So 1000 milligram is the total iron requirement in pregnancy. And since the compensatory efforts by the body are not sufficient to maintain this demand, supplementation of iron is necessary. Okay, even if the patient is not anemic in the first trimester, because of the increased demand, she will need some supplementation of oral iron. Now, also for the calcium, there is increased demand of the calcium for the fetus as well. So to fulfill this demand, what happens is there is increase in the hormone parathormone, increased secretion of parathyroid hormone, increase in vitamin D3, and there is increased absorption and decreased excretion of calcium by the body. Now, regarding the hematological changes, okay, this hematological changes is very important. You might be asked a short answer question about write the hematological changes in pregnancy. Okay, cardiovascular changes, hematological changes are frequently asked questions from this topic. So, what you need to know is in the blood is formed by plasma volume and the cells, right? And RBC is one of them. during pregnancy, the plasma volume is increased by about 40%, 40 to 50%, you can say. Okay, plasma volume is increased by 40 to 50%. However, the red blood cell volume is increased by up to 30%. So when the fluid is more and the solid content is less, what happens? There will be hemodilution. Okay, because of increase in plasma volume by more than that of increase in RBC volume, there is relative hemodilution. This relative hemodilution has several functions. Okay, first is to protect the mother and fetus against the effects of decreased vascular resistance. As we have already known, because of the effect of progesterone, the muscles of the blood vessels are relaxed during pregnancy. So there is decrease in peripheral vascular resistance. Decrease in peripheral vascular resistance leads to decrease in blood pressure, right? This decrease in blood pressure has to be compensated by to some extent. So this some amount of compensation is done by increase in blood volume by the body. Okay, this is one of the function of increase in blood volume. Another function is to ensure that the mother does not suffer from severe anemia because of blood loss during delivery. Okay, some amount of blood loss is anticipated during delivery. If there is no increase in plasma volume, what happens? Even if 500 amount of blood is lost, that will be a significant amount for the mother. However, if it is diluted, the volume is increased and it is diluted, what happens? 500 500 ml amount of blood loss does not contain as much RBCs as the 500 ml of blood volume in a non-pregnant state. Okay, because in pregnancy it is diluted, so there will be less amount of loss of RBCs. Okay, so this helps to safeguard the mother against the effects of blood loss in delivery. Okay, now because of hemodilution, the hemoglobin level in pregnancy falls. Okay, it falls from 13.3 gram per deciliter in non-pregnant state to 10.9 gram per deciliter in pregnancy in one of the study. WHO has defined anemia as hemoglobin level of less than 11 gram per deciliter. Okay, this is the cutoff given by the World Health Organization. However, Royal College of Obstetricians and Gynecologists, RCOG, has defined anemia in pregnancy as different level of hemoglobin at different times. Okay, in the first trimester, it is said as less than 11 gram per deciliter. So if the hemoglobin level is less than 11 gram per deciliter in the first trimester, that is anemia. However, in second and third trimester, if it is less than 10.5 gram per deciliter, then only it is anemia. This decrease in the cutoff level is because of the hemodilution. Okay, to compensate for hemodilution, they have reduced the cutoff value. So in the first trimester, if it is less than 11 gram per deciliter, that is anemia. In the second and third trimester, less than 10.5 gram per deciliter, and in postpartum period, less than 10 gram per deciliter. These are the cutoff values given for anemia in pregnancy by Royal College of Obstetricians and Gynecologists. However, by WHO, the cutoff is less than 11 gram per deciliter. Okay. Now, if you look at other blood components like white blood cells and platelets, in the white blood cells, you will notice increase in size of the increase in number of WBCs. And this increase is mainly neutrophilic leukocytosis. Okay, neutrophilic means there is more increase in neutrophils compared to other white blood cells. This leukocytosis can range from 8,000 to 20,000 per cubic mm in labor. Okay, in labor, up to 20,000 per cubic mm of WBC is normal. Can anyone tell me what is the normal value of WBCs in normal person, in an adult male, let's say? Anyone?
4,000 to 11,000 per cubic millimeter.
Very good. Okay, for the 4,000 to 11,000 is the cutoff given in a normal adult. Okay, but in pregnancy, this cutoff is increased. So even if it is up to 20,000, you have to consider it as normal. Okay, unless the patient is symptomatic, like the patient has fever or there are other localizing signs of infection, the WBC count of up to 20,000 is normal. Okay. Similarly, the erythrocyte sedimentation rate is increased. Okay, this is increased up to 4 times. This is because of hemodilution and increase in level of fibrinogen and other clotting factors. If you look at the plasma proteins, the total plasma protein is increased. Okay, the total amount of plasma protein is increased. However, because of hemodilution, the concentration of plasma protein is less compared to the non-pregnant state. You understood my point? The total amount of plasma protein is increased. However, because of hemodilution, the concentration of the plasma protein is decreased. This decrease in concentration of plasma proteins leads to decreased colloid oncotic pressure. Okay, and this is one of the reasons for the edema in pregnancy. Okay, serum albumin level also decreases by about 30%. There is slight increase in level of globulin. In the non-pregnant state, the albumin to globulin ratio is 1.7:1. Okay, albumin is 1.7 times more than that of globulin. However, in pregnancy, this ratio is decreased to 1:1. Okay, that is the amount of albumin and the amount of globulin are almost same. Now, if you look at the clotting factors, the fibrinogen level is increased by up to 50%. In the non-pregnant state, it is around 200 to 300 milligram per deciliter. However, in pregnancy, this can increase up to 300 to 600 milligram per deciliter. There is increase in fibrinogen level by 50%. Okay. Similarly, the clotting coagulation factors like factor 7, 8, 9, and 10, they are appreciably increased. They are markedly increased. Factor 7 is involved in which cascade? Extrinsic pathway or intrinsic pathway? Anyone?
Extrinsic.
Very good. Okay, this is this is involved in the extrinsic pathway or tissue factor involving pathway. Okay, factor 7, 8, 9, and 10 are increased in pregnancy. This chart is important because this can come as a multiple choice question to you. Okay, which of the following coagulation factors is increased in pregnancy? Which of the coagulation factors is decreased in pregnancy? Okay, so you have to memorize this. So factor 7, 8, 9, and 10 are increased. Factor 2, 5, and 12 may be unchanged or slightly increased. Okay, and the only factors which are decreased are factor 11 and factor 13. Okay, factor 11 and 13 are the only factors that are decreased in pregnancy. Other factors like factor 7, 8, 9, 10 are markedly increased. Factor 2, 5, and 12 are unchanged or slightly increased. Okay, and if you look at the platelet count is usually constant. Okay, however, you may notice some amount of decrease up to 15%. This is attributable to increased destruction of the platelets by the immune system of the pregnant ladies, and also by the hemodilution. Okay, the platelet count can be static or slightly decreased. However, there is no change in clotting time. Now, if you look at the renal system, in the urinary system, the kidneys increase in size by 1 centimeter. Okay, both of the kidneys increase in size. There is dilatation of the pelvic ileal system and the ureter. Glomerular filtration rate is increased by 50% throughout pregnancy. Renal blood flow is also increased by 50% in early pregnancy. Okay, all of these lead to increased secretion of urea and creatinine in the urine. Okay, there is more filtration of urea and creatinine through the urine, so the serum urea and creatinine level are decreased in normal pregnancy. Okay, this is the point you have to note. Serum urea and creatinine are decreased in normal pregnancy because of increased filtration by the kidneys. Now the ureter, you may notice hydronephrosis and hydroureter. Okay, this is more prominent on the right side because of texture rotation of the uterus. In the bladder, you will note some congestion and edema. Okay, because of increased vascularity, there will be increased frequency of micturition. The pregnant females have increased tendency to have micturition. Okay, this is because of the compression of the bladder by the gravid uterus. As early as 6 to 8 weeks of pregnancy, when the uterus gradually enlarges in size, it compresses the bladder that lies anterior to it. So when it compresses the bladder, there is increased sensation of urination. So the frequency of urination is increased. Okay, so this is in the first trimester. But as the uterus enlarges in size and it becomes an abdominal organ, then it no longer can compress the uterus. Okay, so it no longer can compress the urinary bladder once it becomes an abdominal organ. But near term, that is in the third trimester before delivery, still again have some compression. because there will be distension of the lower uterine segment as well by the fetus. Okay, so this distended lower uterine segment compresses the bladder, and this leads to increased frequency. And in some cases, you will also notice some urinary incontinence. Stress urinary incontinence refers to involuntary leakage of urine by the pregnant ladies when there is any amount of stress, like coughing, straining, sneezing, okay, in any of these, or running or jumping. If the pregnant females do any of these activities, then they may have some involuntary loss of urine. This is known as stress urinary incontinence. This stress urinary incontinence is normal to some extent, and this is because of the weakness of the urethral sphincter, because of the effect of progesterone. Now, in urine, glycosuria is normal. Okay, glycosuria is the passage of glucose in urine. This glycosuria is because of decrease in renal threshold of glucose. During pregnancy, the renal threshold of glucose is decreased, so more amount of glucose is passed through the urine. However, if there is persistent glycosuria, there is persistently passage of glucose in the urine, then we have to suspect the possibility of diabetes mellitus. Okay. Next thing is proteinuria. Proteinuria as such is not a normal phenomenon. This is not evident in pregnancy except in slight amounts after labor. Okay, after labor you might note some amount of passage of protein. However, during pregnancy, if the protein is excreted in the urine, you have to think it as pathological. Okay, and the cutoff value that is taken is 100 milligram per deciliter. Okay, if it is less than 100, that is, if it is more than 100, that is called trace proteinuria. If it is more than 300 milligram per deciliter, it is called as 1 plus. More than 1 gram, it is 2 plus. Similarly, it is classified like that. Okay. However, less than trace amount of proteinuria is normal. But if it is more than 1 plus, then you have to suspect hypertensive disorders. Next thing is about hematuria. Hematuria is the passage of blood in urine. Okay, this passage of blood in urine is not a normal phenomenon. This is usually seen in cases like urinary tract infection, if there is any obstructed labor or difficult labor, if there is instrumental delivery with the use of vacuum or forceps. Okay, in those cases, there will be some hematuria. Otherwise, hematuria is not a normal physiological change in pregnancy. Only some form of glycosuria is a normal physiological change. Now let us go to the changes in endocrine system. Okay, starting with the pituitary gland, the pituitary gland increases in size. The size of the gland becomes twice that of non-pregnant state. Okay, that is increase in size by 100%. Because of the increase in the pituitary gland, there is increase in secretion of the growth hormone, which leads to weight gain in pregnancy, increase in secretion of the antidiuretic hormone and oxytocin. This hormone leads to edema of pregnancy, and there is also increase in the secretion of prolactin hormone. Okay, this prolactin hormone contributes to lactation. Okay, the increase in size of the pituitary gland is important because there is a pathological condition that can occur when postpartum hemorrhage occurs. Okay, during pregnancy, as the size of the pituitary gland is increased by 100%, there is increase in the blood flow to this organ by also 100%. Okay, the pituitary gland receives 100% increase in the blood flow, blood supply to the pituitary gland in pregnancy. However, after delivery, if the patient undergoes any form of hemorrhage that is significant, okay, if she has significant postpartum hemorrhage, then what happens? There will be hypotension, and the pituitary gland that was 2 times larger than in non-pregnant state does not receive enough blood supply. So what happens? There is ischemic necrosis of the pituitary gland. This is known as Sheehan syndrome. Okay, Sheehan, Sheehan syndrome. Now, if you look at the thyroid gland also increase in size. Okay, this increase in size is because of the hyperplasia of the gland. Because of the increase in the level of estrogen hormone, there is increased thyroxine binding globulin. So increase in thyroxine binding globulin will lead to increase in the total amount of T4. However, the circulating T4 and TSS levels are normal. Okay. Similarly, the serum iodide level falls during pregnancy because of increased clearance of the iodine by the renal system. So the iodine intakes also should be increased in pregnancy. Okay, from 15 microgram per day to 200 microgram per day. The iodine requirement during pregnancy also increases because of increased clearance of iodine by the renal system. Now the adrenal gland also increases in size. Okay, this increase in size is mainly because of increase in the cortex. There is increased secretion of serum cortisol, deoxycorticosterone, corticosteroid binding globulin, ACTS hormone, aldosterone. Okay, all of these hormones are responsible for increased water retention and the edema of pregnancy. Okay, now let us look at some of the hormones that are produced within the pregnant uterus. Okay, there are some pregnancy specific hormones like HCG and human placental lactogen. HCG is human chorionic gonadotropin. Okay, there is increase in secretion of hypothalamus related hormones like gonadotropin releasing hormone, corticotropin releasing hormone, pituitary related hormones like prolactin. Okay, other peptides like insulin like growth factor, vitamin D3, parathormone, renin. Okay, and some steroid hormones like estrogen and progesterone are increased. Okay, these are the hormones that are increased in pregnancy. Let us talk a bit about the human chorionic gonadotropin. Okay, this is the main hormone that is increased. This is the glycoprotein produced by the placental syncytial trophoblast. Okay, the main function of this hormone is to maintain the corpus luteum production of progesterone. What happens? The corpus luteum secretes the progesterone hormone, and this progesterone is a hormone that helps to maintain the uterine quiescence. Okay, that helps to maintain the uh, uterine quiescence. That means uterus is silent, it doesn't contract, and it helps to maintain the pregnancy. Okay, so this HCG, human chorionic gonadotropin, helps to maintain the corpus luteum production of progesterone. This also stimulates the fetal testosterone secretion in case of male fetus, and it also regulates steroid biosynthesis. Okay, the level of this hormone is first seen in maternal blood, or first appears in maternal blood 10 days after fertilization. This is peaked at 9 to 10 weeks. Okay, and after 20 to 22 weeks, the level of HCG hormone is plateaued. Now let us look at some of the gastrointestinal changes. Okay, in the gastrointestinal tract, there is increased congestion of the gums. Okay, the gums become swollen. So the pregnant ladies may come to OPD with complaints of gum swelling, some bleeding from the gums during brushing. Okay, this is common in pregnancy. This increase in congestion of the gums and increase bleeding during brushing of teeth. Okay, this is because of the condition and the effect of the hormone estrogen. Okay, and there is thiarism. Thiarism refers to increased salivation. Okay, there is increased salivation during pregnancy. Another change is the change in muscle tone and motility of the entire GI tract. Okay, in the GI tract, there are muscles. These muscles are affected by the hormone progesterone. Progesterone is a muscle relaxant hormone. So what happens when the muscles of the GI tract are relaxed? Their tone is decreased, their motility is decreased. So the gastric emptying time is delayed. Okay, in non-pregnant state, in normal patients, in adult females, our gastric motility time is decreased. Sorry, the gastric motility time is increased during pregnancy. Okay, because of the effect of progesterone hormone. So you will have constipation, and there will be more water absorption. When the gastric emptying time is delayed or increased, more of the water will be absorbed by the GI tract. So there will be constipation. Okay, and patient also can complain of heartburn. There will be hemorrhoids. Okay, why there is hemorrhoid is because of increased venous congestion in the lower limbs and in the lower part of the body because of the compressing effect of uterus on the vena cava. Okay, in the liver, all of the hormones are slightly decreased or unchanged. However, alkaline phosphatase is increased. Okay, this is the only hormone that is increased in pregnancy in the liver. Similarly, the gallbladder becomes atonic. This is also because of the effect of progesterone. So when the gallbladder is atonic, there will be less secretion of the bile. So when the bile is stagnant, this leads to formation of stones. So gallstones or cholecystitis are common pathological conditions in pregnancy. Okay, gallstone formation is because of the relaxing effect of progesterone on the gallbladder and bile stasis. The appendix may be displaced upwards and laterally. Okay, because of the uterus, appendix is displaced upwards and laterally. These are the gastrointestinal changes in pregnancy. Now, in the musculoskeletal system, with increase in uterine size, the there is progressive lordosis. Lordosis means the anterior part of the body is protruded. Okay, that is called lordosis, and there is waddling gait because it's like carrying a heavy object tied to your abdomen. When you try to walk, it's difficult. Okay, so this leads to waddling gait, and the patient can also have backache. Okay, this backache is because of the stretching of the ligaments when the uterus increases in size. Okay, in the nervous system, there will be increased nausea and vomiting. Patient can have sleeplessness, mental irritability, and there can be carpal tunnel syndrome. Carpal tunnel syndrome occurs when the median nerve is compressed, right? The connective tissue content is increased. When the connective tissue content is increased, the knob within the connective tissue is compressed. So this is to carpal tunnel syndrome. Okay, so this is all about the changes in different systems.